Thank you for joining our webinar series in recognition of World Encephalitis Day. In this topic today, we're going to be talking about different treatment and therapy options that maybe you did not understand at the time you were discharged. A lot of people say that once they were discharged, they left the doctor and were kind of on their own. So, in the spirit of helping educate and inform on different areas where we can actually have the opportunity to improve, we're going to be speaking today with Kristi Kelley. She's with Baylor and is a therapist there and has seen a wide variety of different options that are available for people that have had any type of brain injury, including encephalitis. So we appreciate her time. Before we get started, just to kind of let you know a little bit about Encephalitis 411. Our mission is simply to improve the quality of life for those impacted by encephalitis. And while that sounds like a very simple statement, it's a very large statement given all the different challenges that we all face with this brain injury. Both survivors and caregivers, we work with them on the hotline and in-person meetings and through our website, as well as Facebook, to help with awareness and advocacy. We help people along their journey to make sure that it can be a smoother ride. We also work with the physicians. We have a medical faculty of outstanding medical folks, healthcare side, that all are also doctors that treat. They've seen collectively thousands of cases of encephalitis. So we're very honored to have a very outstanding medical board. And then also working with the general public, that we feel like the more awareness that we do, the more that people can think of encephalitis as a possibility in the diagnostic phase during the acute phase, so that they can get better treatment in general. We have several initiatives with our nonprofit, and that includes working with the medical community to broaden the amount of education. We've also spoken at universities for students that are going through medical school in the latter phases of their education, so that they can identify better with what the encephalitis experience is like. We also work, as I alluded to, with survivors and caregivers, and we have a lot of good things going on. So we appreciate you following us. If you're not already following us on Facebook, we certainly encourage you to come there, and you can see all the cool things that are going on this year. Again, this is World Encephalitis Day. It's why we're wearing red, and today we're covering several different webcasts, as you might have already seen, some of them throughout the day. And also tomorrow, for people in the Dallas area, we're having another event for Encephalitis World Day that will include Pate Rehab and the Center for Brain Health. Part of this being brain plasticity, which is really dovetails really nicely into what Kristi's going to be talking about. As I mentioned at the beginning, a lot of people did not get much of an education or information about what types of treatment and therapies are available. And so what Kristi's going to do is kind of walk us through how an injury of any sort, whether it's encephalitis, a stroke, or even a car accident, impacts the brain and the different parts of the brain and how therapies can help in the recovery journey. So Kristi, with that, I'll turn it over to you.
All right, thanks, Becky. So I want to talk a little bit about the definition of encephalitis, being that it is an acquired brain injury. But what is important to remember is that no one person is the same. So it very well may be the location of the brain as to what deficit that patient may carry. So for instance, if it is in the Wernicke's area, it very well may have affected the understanding of language, versus if it's in the frontal lobe, it's more of what we call our executive functioning, which is a place where we plan and organize, and even our emotional control is in that part of the brain. As you're going to see on this picture, we've got the Broca's area, which could be expressing language, as well as the occipital lobe, which is typically related to vision, and the parietal lobe, which is your perception and your spatial awareness, and then the temporal lobe really having to do with memory. So there are various deficits or even diagnoses associated on top of encephalitis that you may find or hear definitions of One could be the term aphasia, which would have to do with be a description of challenges with language. The other one could be a cognitive impairment or an executive functioning impairment, and that is really encompassing probably the frontal and temporal lobe primarily, but it very well also could be vision, which would be the occipital and parietal lobes. So I think it's important to remember that it could be specific to the area of the nervous system that was affected, determining what deficits may be present, and that no one patient is the same.
Yeah, we find that even though a lot of us share very similar residuals or sequela, that really we all are very different and unique, both in the way we presented our original symptoms as well as what we experience on an ongoing basis. But when you mention aphasia, it makes me think about a young man in the Ohio area who has a hard time understanding what words to use, and the family plays a game of kind of guessing what something means. So he used the term whipped cream in a cornfield, and the family got a kick out of that. He was talking about a baseball team that had some really good talent, and what he was expecting to say was the cream of the crop. So we see this a lot. We kind of joke ourselves. Sometimes you just have to laugh, but yeah, that's one area that I know in particular people are interested in hearing about as you go through these. Would you like me to move to the next slide?
Well, I do want to just piggyback. So that statement would actually be referred to as what we call a semantic paraphasia, and that would be associated with the diagnosis of aphasia, but you can also have the medical diagnosis of what we call encephalitis.
Okay.
Not to throw out too many terms or too many things, but sometimes it's good to have a way to describe it when you might be visiting with your doctor.
Great.
So now we're going to kind of go into the different areas of therapy. And this is really just to give an overview based on each founding association, national association with each therapy, just so you can have a better idea of what each therapy does, as you may be asking questions when you're going and visiting with your doctor. So the American Physical Therapy Association defines their practice to be transforming society by optimizing movement to improve the human experience. Typically in a medical setting, we are going off of a medical diagnosis in which then we are looking at how do we maximize the quality of life, which could be restoring, maintaining, or promoting mobility and functional ability. And also many times patients have pain, so that may be trying to manage that pain. In physical therapy, just the founding understanding and education, they do a lot of training in that area. So especially in the hospital, or even following more from my perspective coming in an outpatient facility, it's our job to make sure as even a therapy team that patients are preventing falls in physical therapy, that they're working on their balance, they're moving better, they're not dizzy, they don't have headaches or pain or fatigue, and also they're just being able to have a good fitness and endurance program. We know with encephalopathy, a lot of times there is a presence of pain and fatigue, and those are things that your therapist can speak to you about, and maybe strategies in trying to make that a little bit better, as well as to correspond with your doctor. This is very broad statements in terms of what physical therapy does. These are their encompassing treatment definitions, so to speak. So big education piece, transfer training, an example of that would be getting out of the bed, getting off the toilet, getting into the car. Gait training would really be related to essentially what it says is your waist, and being able to balance your legs while walking, and being able to also go from different surfaces from one thing to another. As well as through both of those activities, you're working on strengthening, and many times they're trying to build endurance. So the therapy may be like a stair step, meaning they're not going to start with you on something you can't do. They're going to start with where you can go and then make goals from there. Flexibility and balance are big, and as well as another area of their treatment is vestibular therapy, and really that is addressing dizziness. That could be an effect of encephalitis. However, it just, again, we're talking about whatever part of the brain we're referring to in which whatever symptoms may be a result of that.
And Kristi, are there certain specialists within the PT environment if somebody has dizziness? One of the other webinars we did that came up quite a bit, and it's certainly a comment that we get pretty frequently in the people that call our hotline is the dizziness. Do they see a physical therapist for that, or is that like a vestibular discipline within physical therapy?
So I will say physical therapists are specially trained if that is a route that they chose. So that may be something you want to ask when you are meeting your physical therapist. A lot of times the referral source may come from an ear, nose, and throat doctor, in which maybe the neurologist has referred you to. So those results from that vestibular testing that the ear, nose, and throat doctor may have done may very well be a continued referral, and the physical therapist is actually going to be the one to treat it. I often know too that audiologists, in terms of evaluating hearing, based on some of their results, they may also have found some dizziness components, in which an ear, nose, and throat doctor is probably the one that has authorized that leads to you maybe addressing that with physical therapy.
Okay.
Vestibular therapy, a lot of times because of the dizziness, there is balance changes. And so they're doing a lot of drill-based exercise to help manage the dizziness, but also improve balance.
Great, great, thank you.
So occupational therapy, I feel like the title of theirs is just as much of a misnomer as our title of speech therapy, because really their vision is helping people across a lifespan. So those activities of daily living may very well be changing depending on what lifespan that you're a part of. Occupational therapists with young children are working on motor skills that maybe those children have not acquired, whereas with adults, we are talking about physical and cognitive changes to maximize your independence. So are you lifting and moving things in the kitchen? Are you needing to drive your car and you need to work on the skills that it's required for you to drive your car? Is it getting dressed? Is it getting off the toilet? Is it doing those more basic, what we call activities of daily living, versus independent activities of daily living is even bill management or managing your calendar. And there is a little bit of crossover between occupational and speech therapy in that regard. And again, I think it all stems back to what part of the brain are we addressing and what is it that we need to do in order to be able to maximize independence. Because they really look at therapy from a holistic approach as defined by their national association, and using the environment as an integral part of the therapy process. So they may look at adaptive equipment that's required to do a certain task. A lot of times there might be a splint that is needed because there's hand weakness, or there very well may be something adapted to a pen so that the grip on the pen is actually easier for you to write. Those are just very minor examples, but really they're wanting to look at your ability to maintain safety. So you need to be able to have the upper and lower body strength and the range of motion in order to complete basic tasks, progressing more to what we call complex or independent ADLs, which address cognition, that may include things like vision and safety. And that's where a lot of times occupational therapists are helping with the question of, is driving appropriate? Because they're looking at the environment in which that activity would be completed, whereas speech therapy may actually be addressing the cognitive skills that are required to do that task. So I feel like in the hospital, occupational therapy is more basic in terms of just your basic grooming, dressing, bathing. And then as you progress in an outpatient setting, the speech pathologist and the occupational therapist really work together because there's such a crossover between physical and cognitive changes.
Okay.
So their national association defines their treatments, also including much of education, which you're going to see across all medical professionals for sure. You're looking at gross motor activities as well as fine motor activities. So gross motor more being using the arms and lifting and getting a big activity done, versus fine motor is a lot of times with your hands and your fingers when you're having more weakness. And they may be doing exercises to improve those more detailed tasks. Looking at lower motor extremity, upper motor extremity, as well as combining those together. And we often encourage mental and physical tasks happening together to really see how that motor movement plays out. And then, of course, they're taking maybe some adaptive equipment that was recommended by physical therapy, like a walker or a cane, in order to engage in like something like a kitchen task, or even doing laundry, because there may have to be a change in how that task is done, but also facilitating the independence, as well as looking at vision if the goal is to resume driving, but also vision in terms of, has the brain changed the ability to see something on one side, and they may be helping you with cueing and scanning and visual processing so you can improve that side of the brain, especially if we're talking about those changes with the parietal and occipital lobe that we talked about at the beginning.
Just to interject one example on the vision, I think we say this a lot in the encephalitis world is, you don't know what you don't know. And I know for me in the initial, probably a couple of months or so, I tried to drive, and I'm a fast driver, so I'm usually in the left lane. And I would see the cars that I wanted to pass until I got close to them, and it felt like everybody was coming into my lane. And not until I had some therapy and talked to my optometrist did we realize that I was missing a lot of peripheral vision, which gave me that odd feeling that people were coming into me. So clearly I quit driving for quite a while, several months, until we could try to work around that. But I know a lot of survivors deal with some of the vision issues, especially peripheral vision challenges. So just wanted to note that for others to kind of consider. Sometimes you don't know what the problem is until you kind of have somebody either from a therapy or a medical perspective kind of explore, why are you having these odd sensations? So I will move on to your specialty on speech therapy.
I guess I'll go back for just a second.
Oh, sure.
So that also echoes some of the more complex, I guess, outpatient level occupational treatment does include some visual, spatial, and visual processing activities that might be related to writing a check or doing bills so that those visual things can be noted. Neuro-ophthalmology is often really recommended over just a regular ophthalmologist, especially if encephalitis is indeed the medical diagnosis, because they're going to know more about the brain and really looking at why is the vision changed. So that might be something for you to talk to about in order to get those appropriate referrals.
Yes, I didn't even know the neuro-optometry field existed until maybe just less than a year ago. I'm actually using prism glasses that help when I work on the computer or doing any type of reading, and it certainly has made a difference. I had no idea that the eyes were fighting each other, which was one of the results of encephalitis. So I'm glad you brought that up. Several people have wanted us to talk about that, so I'm glad that you did.
So moving on to speech therapy, again, I think our field name is a little bit of a misnomer because it encompasses so many different things. We want to, just like physical and occupational therapy, we want patients to be independent. And in our field, It's defining communication of wants and needs, exchanging thoughts and ideas. I would also add the ability to think and decision make for whatever the tasks may be for daily living. And another component of our field, which really we're not going to talk a lot today, but swallowing could be an area of change. And if indeed that is a concern, that may be something for you to visit with your doctor about. In terms of just the actual speech production that our field defines, we are talking about the physical production and motor production of the sounds that make speech either clear or fluent, as well as the use of the voice. Whereas language, which we talked a little bit at the beginning about the definition of aphasia, that's the ability to use words to convey a message. So being able to express words to convey a message, as well as being able to understand those in conversation. So that's really going back to that Wernicke's and Broca's area of the brain that we were talking about that may be affected. And then our overall goal is really looking at communication as a whole and how patients are able to exchange information with other people. So because there's a cognitive component oftentimes with encephalitis, it does affect patients' ability to exchange information because their memory may also be impaired.
Yeah, and a question for you, I'm not sure which type of therapist this is, but a lot of people have oversensitivity for both light and sound. Some people wear sunglasses a lot. Some people wear headphones to just block out some of the loudness, which is funny because it makes some people talk louder to them when they're really trying to filter out the sound. But is there a specialist within the therapy network that is better for that type of issue?
I think that we all address that. So I think with speech therapy, if we are working on cognitive or thinking skills, and it sounds like you're describing issues with attention, and that there's an over sensitivity to something, excuse me, we may alter our room, meaning we might dim the lights, or we might go to a quieter place to actually complete that session in order to address that, to get the patient to a place where maybe that sensitivity isn't as heightened. I would also say with fatigue in general, sometimes when you're in therapy and you're having to do a lot of different repetitive drill, that those symptoms may be more prominent. I think that's what makes us a multidisciplinary approach with all the therapies, because we're probably all addressing them in different ways.
Got it. And I'm also glad you mentioned the tongue and swallowing. I know that some people, especially those with autoimmune types of encephalitis or West Nile that hit the Dallas area pretty significantly back in 2012, that motor skills and different muscles, especially some of the vocal cord area, has been a real challenge for them. So it sounds like a speech therapist would be better for people that have had difficulties or residuals that kind of manifest itself in the speech area, specific to the tongue and the vocal cords. Is that correct?
Yes, and I would just share those complaints with your doctor because they're going to know to make that referral.
Okay.
So I was talking to this a little bit. I think cognitive therapy can be misinterpreted sometimes because there may be different people along the medical continuum that could be addressing this. In terms of speech therapy, we're looking at cognitive communication, meaning is there a difficulty with an aspect of communication due to disrupted cognition? So attention, memory, executive functioning, verbal reasoning, that's all encompassed in those lobes that we talked about at the beginning with the temporal and the frontal, or temporal and frontal lobe. However, I do feel like sometimes there is a neuropsychologist brought into the continuum in which they may have identified these deficits and may be working with a speech pathologist in terms of cognition, as well as even the occupational therapist may even be addressing these not specifically to the actual task, but again, they're looking at the environment in which the task that the patient is completing it in, and are they needing to address parts of the memory or parts of the attention in order to make that particular activity of daily living easier. Oftentimes we see them addressing sequencing of maybe doing laundry because the patient has a memory deficit and they're having a trouble remembering how to do laundry. So they're looking at the functional task a lot of times. So we are together coming up with a way to remediate thinking skills in order to support communication as well as independence with daily living skills. So then I kind of want to mention a little bit of maybe some examples of cognitive strategies. So oftentimes within therapy, we are addressing better ways to manage medications. We might be addressing better ways to manage daily schedules by going over agenda book or methods or ways that those daily schedules are being planned. In terms of speech and language, we may be addressing word finding strategies to help daily conversation, or we may very well be addressing intelligibility of speech, slowing down and over articulating so that speech and language is more accurate and efficient, as well as providing cognitive training that alludes a little bit to what Becky was talking about. So if we are needing to train attention and get attention better, let's say someone's going to go back to work part-time and they need to be able to operate in a distracting environment, then that may be something that we actually progress and address. So our therapies really look at the difficulties and we develop a hierarchy and a systematic way to getting to hopefully the ultimate goal. So I want to speak a little bit about the referral process. You've probably been asking yourself, these therapies are all great, but how do I end up there? Or maybe I had those therapies in the hospital, but I'm noticing that I'm still having some trouble and I may need more of those therapies. So I would suggest starting with your primary physician and letting them know that you're having the difficulties, and maybe you've got some good examples from what we've talked about today. I think another part that we didn't really allude to is there are sometimes really fatigue factors that affect overall activities of daily living. There could be endurance factors. There could be other medical complications that have come up since you got out of the hospital that may be affecting the ability to complete what you need to do for the day. So if your primary doctor is able to refer you maybe to a neurologist to get some more information, that may be one route, or your primary doctor may have one way that they want to do the therapy and then refer to a neurologist. I'm not saying that you absolutely need a neurologist, but you're going to need your primary doctor to support a referral to a neurologist because you are not able to just walk into a neurology office for an appointment like you can your primary physician. If you do end up in the neurology office, oftentimes they may want to redo MRIs, they may have some additional workup that they are able to do, and then they are also able to prescribe your ability to go to therapies, and they're going to decide maybe which one of those therapies or all those therapies that's most appropriate.
So Kristi, a question for you here. A lot of people, again, one of the reasons we chose this topic is a lot of people didn't have the opportunity to go to different therapies. When you're requesting this to a doctor, do you have any advice in terms of certain terminology to use or how to characterize the symptoms so that that doctor can understand why you would need that? And the reason I ask that is a lot of times encephalitis is what we call the invisible illness because we look fine, we, it's not always apparent of some of the challenges. and sometimes it's hard to kind of put a finger on exactly what's going wrong, or maybe you present well to others, but inside you're just, everything is a challenge to speak or find the right words. So what tips do you have in terms of how a patient or a caregiver can advocate for themselves to get this support from their doctors?
Well, I would almost suggest journaling behavior, and I would maybe ask a caregiver to write those things down and look at it over a period of a little bit of time, so that when you actually go to that neurology appointment or that primary care physician's appointment, you have some examples. Because oftentimes I hear patients tell me that they go to the doctor, but they don't really know what to ask. So if you can jot down on paper what your troubles are you tired? Are you having trouble talking on the phone? Have you gone to the bank and felt like that was a really difficult task? Have you gone into the kitchen and you aren't able to lift groceries into the pantry anymore? Or maybe you are in the bathroom and you just really don't feel steady on your feet in the shower, and you feel like maybe there's more support that you need. Those are really great examples to indicate to a physician, because they're objective, and they also give an indication that there's been a decline in your activities of daily living. But I would also say, to your doctor, that if there are things that you're really wanting to progress back to, and you're just not sure if that's going to be a feasible option, and maybe talking about what those things are could also show the need for therapy as well. And really, it's up to the physician to make those decisions based on their medical training and based on their evaluation of the particular case. But I think if you've even had to go back a second time and you're still having trouble, they should be able to know that therapy might be a good outlet for you. Because we then are responsible. All of those treatments that I spoke about are written in what we call medical documentation, just like your physician would. And it's our responsibility to communicate that progress to your physician, so that when you are going back to those appointments, they're able to evaluate that there's been a change and they can continue to authorize the support for ongoing therapy.
Great. Thank you. Anything else you want to comment on the referral process?
I guess I just want to talk about, I know that there have been patients of my own that I have seen that have been able to go back to work, and when that discussion comes about and it's appropriate, the neurologist may be someone to visit with, because that may be someone that you have been corresponding with your care, and they also may have outlets, or even the speech pathologist may have outlets to what we call a neuropsychological evaluation. And that would be a way to maybe help support accommodations that could be appropriate for your return back to work. Okay. But I do just want to echo that all of these particular items are supported by a physician, and we as therapists or even additional clinicians like a neuropsychologist are reporting those back to the doctor, so that we're all on the same page.
Great.
So our ultimate goal of therapy is not necessarily to have you obtain all your prior abilities, but for you to be independently and functionally as mobile as possible, and also safe. So that may be using the equipment that we've talked about. It could be a cane, a walker, in order to still get around and do things that you enjoy. And I really feel like that is a benefit of therapy, that we can explore and interview and talk about those things over the progression of time. So I'm not going to go into a whole lot of detail of this, but I do want to just talk a little bit about the ICF model, in which we as therapists have really adapted this model over time. And it's been more recent that we look at the health condition, as well as what are the patient's environmental and personal factors, along with their body functions and structures, their activities, and their participation. And this may be comparing before and after, but it also may be looking at the current situation and what are the different elements under each one of these conditions, that allows us to really outline what's the most meaningful, realistic therapy plan, so that we can take into consideration the elements of, for in this case, encephalitis, we know what the disorder means. So then we can look at all of the factors to really think of what is realistic. So each one of these areas, we've got some definitions of what those are. So there are a lot of reiterating some of the things that we've already talked about. So the body structures and function may be something that speech is working on with cognition. It could be physical therapy is really working on strength and balance. And occupational therapy may be working on activity tolerance to actually complete a certain task. So a lot of times they'll do laundry while standing. Then you've got the actual activities. So what are all the activities that you want to complete? These are just some examples. And then what are the things that you actually want to participate in? So it's using your body in order to complete a task, and then actually be able to maybe participate in something over time. And these are the factors that are contributing to the completion of those things. And what are even some factors that you may even have to alter or change since the onset of the disease or disorder. So we know that age is a big factor. We know family support is a factor, and the rest of these that are listed here. And it's important for us as therapists to make the plan as realistic as we can to really look at each one of these. And then of course, environmental factors. I think our training, because a big, as you heard, education is under all three of our umbrellas, training is really important. So if you live alone or you live with others, I think that's gonna change our approach. And do you have access to additional resources that you may need? And we may be the facilitators of that. So this is really just a holistic approach that we use in our, what we call our multidisciplinary team. And this is some newer research that most, I feel like most medical clinics with therapy are really addressing, and even within the hospital therapy teams as well.
Great. Well, a few questions came in while you were talking. One person asked if they had encephalitis several years ago, but they're still having issues. Is it ever too late to start therapy? Just because years have passed, does that mean there's not the ability to improve, or could it be that that person could go ahead and initiate at any point in time?
I would say at any point in time. And again, I think I would echo my example of the journaling, and I would really say, you know, make a note of what are the things that are different or the things that have changed, and what are the things that you desire to acquire. And that may really help a physician decide whether or not therapy is indeed supported.
Okay. And another question that was asked is, if you're too fatigued, does that mean you need to wait for therapy, or are there incremental steps to take so that you don't have to wait to start recovering or improving in different areas?
That's an excellent question. It's a little bit loaded, so I'll try to unpack it a little bit. I would say, no, don't wait for therapy. Therapy is what's actually going to make your fatigue better, although it may be a process to get the fatigue better. So I use the examples a lot of times within a daily routine that your brain is really needing rest. And if you're that fatigued, you're gonna need to space your rest out. So an example that I would encourage is maybe rest at 10 and 3 or 11 and 4. And it doesn't have to be sleep, but it could actually just be laying down and getting just a little bit of shut-eye, a little bit of distraction away from, or less distraction away from noise. So it doesn't mean being in front of a television. It means actually being in a dark room with no noise, and just a chance to kind of have a way to calm down and tune out all that extra distraction. So I'm going to answer another piece of that is really the therapy team is going to determine, what is realistic in terms of endurance and what are the things maybe that we need to decide are less priority right now that maybe caregivers can support, so that those really important tasks can get done. And then part of the activity tolerance that I briefly mentioned in that ICF model is being able to help you improve your activity tolerance so that you can do more with the same quality, but it may be taking less is more approach first to get your stamina back up. So I would say therapy is one of the resources that you have to actually get that fatigue better.
Great, thank you for that. And then one last question. This person asked, how soon after hospital discharge should a patient initiate therapy? It sounds like if you've gotten some in-hospital therapy, that perhaps you want a continuation of that as soon as you're discharged, but I'll let you, the expert, answer that instead.
Well, I guess I would go back to the first question is maybe why wasn't therapy even initiated right after hospital stay? And again, every scenario is a little different. Insurance, is definitely a factor, and it's hard for me to know exactly. But I think it's visiting with your doctor and indicating where the troubles are and navigating the medical process after a hospital stay so that you can get those therapies, because the sooner the better. In achieving those goals to be as independent as possible is probably the best outcome.
Great, great. Well, thank you so much. You've been a wealth of knowledge, Kristi. We appreciate all the different aspects that you covered. It's definitely a multidisciplinary approach. And you shared a lot of information that probably most people didn't have the opportunity of knowing in the past, or perhaps it gives them a new path that they wouldn't have known to take otherwise. So thanks for your time and preparing for this. And I just want to tell everybody again that we honor those and recognize everybody, both who have survived and those who have not, that we're recognizing and honoring you today on World Encephalitis Day. Thank you for joining us.
Thank you.
Thanks.